next up, I have the esteemed pleasure of introducing someone who really doesn't need any introduction. He is a man of many titles. We know him lovingly here at the University of Maryland as one of our tenured professors, as well as vice chairs of emergency department medicine. And he's lectured locally, nationally. He's crossed borders for you guys to talk internationally. You might hear him weekly on ECG Weekly or online on Corpendium as well. Next up is Dr. Mattu, who is going to be talking to you guys about something very important, which is unrecognized killers in emergency cardiology medicine.
Great. All right, thank you. Thanks, Eileen. That was really great. A little scary. No disclosures. So I hope people did get a little bit frightened from that lecture, and I'm going to continue the theme of fear here. I realize that at the very end of a conference, most of you probably feel a little bit like this, and I'm not going to try to teach you a lot. I've got 3 things I want to teach you over the next 40 minutes, and everything I'm going to do is just present case after case after case. Every one of these cases is a real case. Some from here, some are mine. A lot of them are screw-ups, and some were sent to me. I'm not going to tell you which ones were. If they're Dr. Butler's, I'll be sure to tell you. Because none of them are Dr. Butler's, actually. All right, so let's jump right in. Case number 1. Case number 1 is from here. There's a 42-year-old man who comes in really sick. He's got a history of liver cancer. He's got multilobar pneumonia. He's tachycardic, tachypnic, hypoxic. He's your classic septic patient. Housekeeping comes walking by the room and says, sepsis, and then walks on by, all right? So I'm not trying to fool you with this. He's really sick. He's also hypoxic to 84%. So you get a quick 12-lead ECG, and it shows sinus tachycardia. No surprise, because he's clearly very dehydrated, all right? So what are we going to do for him? We're going to put him on the monitor. We're going to get him on 100% non-rebreather. Pulse ox only comes up to 93%, so it's a little bit better. But he's starting to get a little bit tired. His lids are starting to get droopy. And what does that mean? It's time to intubate this guy before he has a respiratory arrest. So no problem. You all are very, very good at intubation. He gets intubated, 3-point auscultation, end tidal CO2. The tube is right where it needs to be. He's intubated. But as what oftentimes happens after his intubation, the monitor looks a little bit different. His heart rate picks up, so we're going to get a new 12-lead ECG. And here's the new 12-lead ECG. It's regular, it's wide, the heart rate is 123, and there's no clear PQRS, 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 and so we're going to call this ventricular tachycardia. So he was diagnosed with ventricular tachycardia, that's what the computer is calling it as well, and he gets a bolus of lidocaine and goes right into asystole and died. After he was pronounced dead, the diagnosis was revealed. Too late. We'll come back to that case in a little bit. We'll talk about what it is on this EKG, which if you ever see this EKG again, not only is this not VTAC, but every ACLS antidysrhythmic that is taught in ACLS is contraindicated. All right, case number 2. 46-year-old woman. This is a patient that was at Mercy back when I worked there. 46-year-old woman comes in after 2 syncopal episodes. Each episode is associated with palpitations. So we're going to get a 12-lead. Here's a 12-lead when she's not having the palpitations. But she's also having intermittent episodes where she develops palpitations and goes into this rhythm. All right? And then this lasts for a short time, then she comes out of it. She's gone into this about 3 times in the emergency department, each time passing out or nearly passing out. Unfortunately, she's coming out of it. And so what would you do for her? Well, it looks like polymorphic VTAC. All right, no tricks there. So she gets magnesium. She gets 2 grams of magnesium, and she still keeps having it. So she gets another 2 grams, and then another 2 grams. She's had a total of 6 grams of magnesium at this point, and she's still having episodes of this polymorphic VTAC. But what's different now is that between the episodes of polymorphic VTAC, she's hypotensive, nauseous, and diaphoretic, which is what happens when you get too much magnesium. So we are going to talk about what it is on this 12-lead ECG, which actually gives you the diagnosis and the drug of choice, and it's not magnesium. Magnesium is just going to probably make her become more hypotensive and eventually stop breathing. Case number 3. Case number 3 was from here. 55-year-old woman, history of hypertension, diabetes, and 1 pack per day smoking. Comes in with some shortness of breath and some chest heaviness. And so, of course, we're going to get a 12-lead ECG. And here's a 12-lead ECG. I think you notice that it looks like she's having a STEMI. She's got ST segment elevation in the inferior leads and probably out laterally also in V6. The formal interpretation a couple days later confirmed that this was a STEMI. Formal interpretation just said inferior. I'd probably say there's a little lateral involvement as well. So maybe left circumflex, inferior and lateral, probably left circumflex. You know, I don't really care what vessel it is. I just want to know, do they go up or do they stay? All right. So she's diagnosed with a STEMI. The emergency physicians call up to the cath lab. Cardiology gets a copy of the EKG. They say, absolutely, send her up. Wait about 10 minutes. We're finishing up a cath right now. Send her up in about 10 minutes. And while she's down there during the next 10 minutes, give her some aspirin, give her some clopidogrel, bolus her with heparin. You don't need to start a drip, but bolus her with heparin, and then 10 minutes, send her upstairs. We'll continue the heparin drip. She gets the aspirin, she gets the clopidogrel, she gets a bolus of heparin. 10 minutes later, she goes upstairs, and the procedure starts, and about 10 minutes into the procedure, she has a bradyasystolic arrest. And they figure, well, if she's arresting from an occlusion, we better find that occlusion. So they start ACLS, but they continued the cath, and as they continued the cath, they could not find any occlusive lesion. They continued ACLS for 30 minutes and ended up pronouncing her dead. We'll talk about what it is on her 12-lead ECG, which actually gave the diagnosis. This is not STEMI, but everybody knows it. So what are we going to talk about? Those things sink in. We're not going to talk about research, all right? We're going to talk about practical stuff. We're going to talk about some mimics of ventricular tachycardia. In a lot of lectures, people tell you that when in doubt, it's always better to call it VTAC, overdiagnose VTAC. In this lecture, I'm actually going to tell you why sometimes it can be really dangerous to overdiagnose VTAC, and sometimes you ought to move away from VTAC. We're going to talk about some prolonged QT issues. Now, you guys probably know a lot about prolonged QT, but there's a couple of interesting twists that I want to share with you that I've learned the unfortunate way over the years. And then case number 3, we're going to talk about pericardial effusions and how those can mimic ACS and also PE, conditions that you want to give anticoagulants to, but you'll actually kill people with anticoagulants, potent antiplatelet medications, or thrombolytics. All right, so let's talk about VTAC mimics. Let's start off by just defining ventricular tachycardia. How do you define ventricular tachycardia? Well, VTAC is a regular, wide, complex rhythm without a clear PQRS, PQRS, PQRS. So sinus tach is off the table. It's regular and it's wide. But one of the things that's not typically taught is that before you call something VTAC, you ought to have a rate of at least 120s to 130s. Your computer doesn't know that, and this is not typically taught. There's a major problem when you assume that someone has VTAC, and yet it's not fast enough to be called VTAC. There's some classic mimics of VTAC that can really get you into a lot of trouble when you misdiagnose these patients. All right? So when I talk about 120s to 130s, some of the major textbooks in medicine have confirmed this as well. Jumping forward a little bit, sorry about that. The book at the top was written by Edward Chung, the cardiologist who's really one of the true experts around the world. He was the one who taught me when I was in residency. And he used to teach us 140 was the cutoff. Maybe 120 in rare case, 140. Chow's textbook, which is my Bible of electrocardiography, goes by 140. And then the biggest textbook in all of cardiology, literally and figuratively, Hurst's textbook, The Heart. How can you not believe a textbook called The Heart? This is the textbook. This is the Rosen of cardiology. They go by a minimum of 120 as well. So the authorities on electrocardiography also go by 120, 130, or 140, yet your machine will fool you into thinking it's 100. So there's some other things that you've got to think about when you see rates that are a little bit slower. When you think you're looking at VTAC, but it's not quite fast enough, think about hyperkalemia. Think about sodium channel blockers like tricyclic overdose. Cocaine is a classic example of this, cocaine overdose. And also reperfusion arrhythmias, that classic AIVR. When the patient gets thrombolytics and the artery starts opening up, you oftentimes will see this, and it's a mimic of VTAC. Well, you might say, well, what's the problem with just going ahead and treating all of these as VTAC? The problem is that when you treat these as VTAC, you can actually end up inducing asystole. And this has been published. It's not widely published because people don't tend to iatrogenically kill patients and then run out and publish their case. All right? And I'm going to show you a handful of cases where we learned this the hard way. We did not run out and publish a single one of these cases. Hey, everyone, I kill someone. Let me publish it so everyone can see. All right? So we don't actually know how often this happens. But unfortunately, it probably happens more often than you realize. And I'm going to share some of our mistakes. I'm going to share some mistakes that other people have sent me so you learn from these mistakes so you don't make these mistakes. All right. This is a university case. 37-year-old man came in with respiratory distress. This is from a handful of years ago. And I'm going to ask Dr. Butler to just take a few deep breaths before we get into this. All right. So 37-year-old with respiratory distress, history of hypertension and diabetes, and he was in full-blown pulmonary edema. He's got crackles up to his earlobes. For those of you that still use your stethoscope for other things and reflexes, all right, he's got crackles all the way up. If you get your ultrasound, he's got B lines everywhere. And his pulse ox is 80%, all right? No tricks. He's in full-blown pulmonary edema. So we get a 12-lead ECG. Here's the 12-lead. I'm going to tell you something that the physicians didn't know right now. Right now, this patient was so sick and had a number of other comorbidities that were unknown to the physicians treating him at this moment. Right now, his potassium, he's in renal failure, his potassium right now is about 7.4. Right? Now, in retrospect, yeah, it looks like maybe there are some peak T waves that you see up there. They're not necessarily tall. Hyperkalemic T waves don't need to be tall. They just oftentimes are a little bit sharp on top. But they missed it. They didn't see that. They were so focused on this guy's airway as he's slowly starting to crump. We've got to manage his airway. So the ECG wasn't really looked at that carefully. What ends up happening, he gets a non-rebreather mask, but only slight improvement. So, you know what, it's time to intubate this guy. His pulse ox is at best in the mid-80s. He's got a nitro drip going, but that's not fixing the problem. And he gets intubated with etomidate and succinylcholine. All right? By the way, this is one of the cases a handful of years ago that from an M&M series that we did, which led to us pretty much getting rid of succinylcholine from our ED. All right? So for the people online here at the university, we rarely, if ever, use sucks in our emergency department because of cases. Right after his intubation, his rhythm changes. And here's what showed up on the rhythm strip. Right? It's regular, it's wide, the rate's 105. What does that mean? It can't be VTAC. But the computer is trying to fool you, right? This is just hyperkalemia. It's a mimic. It can't be VTAC. Because the computer's calling it VTAC, this was assumed to be VTAC. He got a lidocaine bolus, and here's the rhythm strip right after the bolus. Going to asystole, could not be resuscitated. After he was pronounced dead, they found that the pre-succinylcholine level was 7.4. What's the problem with lidocaine and hyperkalemia? Again, something that's not typically taught. Hyperkalemia is a sodium channel poison. I never learned that in med school or residency. But hyperkalemia poisons your sodium channel. What type of drug is lidocaine, or amio, or procainamide? Those are sodium channel blockers also. You give a sodium channel blocker to somebody who's already got poisoned sodium channels, you knock out those sodium channels, and it's a very reliable, what we might call, clean kill. It's going to put them right into asystole. That, unfortunately, is what happened. Right? So if that's not enough, here's another case. 64-year-old, this patient already has known pre-existing renal failure, renal insufficiency, and he comes in very dehydrated. He's even more pre-renal from the flu. Gets put on a monitor, and on the monitor, he's got this, regular, wide, complex rhythm. There's no clear PQRS, 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 so nobody's going to call this sinus tach. Kind of bizarre looking. What have we talked about before? Anytime you look at a rhythm and the first word that pops into your head is the word bizarre, bizarre equals hyperK. Bizarre equals calcium bicarb. See someone who's dressed bizarre, calcium bicarb. What the heck? It's not going to hurt. It might save a life. Right? Heart rate's 105. What does that mean? It can't be VTAC. This was thought to be VTAC, and the patient ended up getting a bolus of amiodarone, and after about 5 minutes of the amiodarone, Patient went right into radiosystolic arrest. There's an 86-year-old man who went to a local hospital with an inferior STEMI. Right? No-brainer, inferior wall STEMI, the bradycardic rhythm. They tried some atropine, and atropine didn't work. Then they decided to give some thrombolytics. Perfect. There's no cath lab at this hospital where the patient was seen, so they give thrombolytics. Perfect choice. Exactly what you're supposed to do. So the patient gets thrombolytics, the chest pain's getting better, the ST signals are starting to come down, everything's going well, and then the patient gets transferred over to University Hospital, and the patient's now in the CCU. In about 90 minutes post-thrombolytics at that hospital, patient has a change in rhythm. Now, the patient is still very stable, but the rhythm is different. Blood pressure is pretty good and stable. He's awake and alert, no heart failure. And so they get a new 12 lead, and here's the 12 lead. It's like VTAC, doesn't it? It's regular, it's wide, heart rate's 110. What does that mean? It can't be VTAC. But the computer called it VTAC. The cardiology fellow called it VTAC. And so the patient got a bolus of amiodarone and went right into asystole and couldn't. This was your classic reperfusion arrhythmia. When you give lytics to a patient, as the artery starts opening up, which usually takes 30, 45, 90 minutes or so, as the artery starts opening up, you typically get this little brief run of a reperfusion arrhythmia. It looks like a bunch of PVCs at a slower than VTAC rate. Now, normally this only lasts for a few seconds and goes away, so there's no harm done. Cardiology sees this all the time in the cath lab when they blow up the balloon. The patient reperfuses, they see a bunch of PVCs. What do? Nothing. It goes away. Every now and then, however, it'll last for 4 or 5 minutes. And that's long enough for somebody to get a 12 lead and panic, thinking that they're looking at VTAC. But it's not fast enough for VTAC. But the computer will call it VTAC. The patient usually is fine. It's not a destabilizing rhythm, so the patient's just chilling. They're sitting there doing fine. So it ends up being misdiagnosed as stable VTAC. And essentially what this is an escape rhythm. And if you give lidocaine, amio, or procainamide, you suppress the escape rhythm, which turns this into asystole. The patient dies. And that's exactly what happened here. This was a successful thrombolytic case. If you really want to do something for these patients, I would say go up to the patient and give them a high five. It means that their artery's opening up. But people tend to panic. If you really want to use a drug, you can use Valium on yourself. All right? But you don't need to treat the patient with anything. It goes away. A few other cases here. This is a pre-hospital case. The computer doesn't know what to deal with, but the paramedics thought this was VTAC. Heart rate 116. What does that mean? It can't be VTAC. It's too slow. But they called it VTAC. They gave the patient amiodarone in the field, and by the time the patient arrived, here's the 12 lead. Everything's widening out. Patient got moved on to the stretcher, and as soon as the patient got put on the stretcher, asystole. Patient died. This was a tricyclic overdose. This is a 13-year-old girl. This is from here, a number of years ago, back in our old emergency department. Patient came in here, 13 years old. She was listless, lethargic, blood pressure 115, which is pretty good for her size. And she's got a regular wide complex tachycardia at a rate of 117. What does that mean? It can't be VTAC. Say it with me. It can't be VTAC. All right. Everyone online, say it with me. Great. Thank you. All right. So everyone thought it's VTAC. So they pulled up some procainamide and were getting ready to push procainamide. And then one of our senior residents, Joe Scheiber, EMIMPG5, he stepped up and said, well, wait a second. Why would a 13-year-old have VTAC? She doesn't have some big scar from some congenital surgery. Maybe overdose. So they put the procainamide aside. They had it in the syringe. They put it aside. I was on urgent care, so I'd come over and was watching this. And instead, they gave the patient 2 amps of sodium bicarb. That's it. Nothing more. Just rapid push, rapid push. And after the second amp of bicarb, here's your 12-lead EKG. P waves reappear, QRS narrows, you've got your diagnosis. If this were VTAC, nothing would have changed. This turned out 2 hours later, they found her suicide note and an empty bottle of amitriptyline. What would have happened if they gave procainamide? Dead. So just to sum up case number 1, beware slow ventricular tachycardia. VTach has to have a rate of at least 120 to 130. When it's slower, you've got to think about mimics, and all of those mimics will die if you follow ACLS and give lidocaine, amiodarone, or procainamide. When in doubt, just try a little bicarb or calcium if it's hyperkalemia, but bicarb. Bicarb never hurt anybody. If I gave everyone in this room 2 rapid pushes of IV bicarb, you know what would happen? Nothing. It gets metabolized and it's gone from your system in about 15 or 20 minutes. Your beer or soda might taste a little funny for a little while. All right? That's about it. All right? But if it's one of these conditions, you'll see the QRS narrow right in front of your eyes. You've got your diagnosis. All right. Let that sink in. Think of some good questions for me. We'll move forward. Let's talk a little bit about QT. All right? I think most people know about QT. I'm convinced that prolonged QT and torsade is a more common cause of sudden cardiac death than we've previously recognized. We had a patient on Monday that probably had torsade, came in. Bennett, this was your patient that came in, and she had coded out in the field, and it was probably prolonged QT. She was hypoK and may have been on methadone as well. I really think this is more common than people realize. Now, what do you need to know about prolonged QT? You've got to know the differential. HypoK, hypomag, hypocalcemia. There's a lot of medications that do it, including methadone. It's worth taking a look at those medications when you see prolonged QT. Elevated ICP, acute cardiac ischemia, ACS, can do it maybe a little bit. If you forget that, it's all right. Hypothermia prolongs the QT, but you should really use a thermometer, right, not an EKG. And then hereditary. So that's your differential. Whenever you see a prolonged QT, think about the differential. Now, the QT, really, when we talk about prolonged QT, what we're really talking about is prolonged QTC, corrected QT. And most computers will correct the QT for you based on the Bizet formula. Now, caveats, if there's any tox people out there, they'll always say that when patients are tachycardic or bradycardic, the Bizet formula doesn't work that well. So you might need to use a different formula and figure it out on your own. Okay? Fortunately, when patients are tachycardic, that's actually a bit protective against torsade. So I don't worry too much about it. And the Bizet formula is the most commonly used formula, and we worry when the QTC is over 500. That's not an absolute barrier, but really torsade tends to occur more often when the QTC is over 500. Pretty uncommon if it's under 500. All right, so that's when I really start to worry about it and check those electrolytes. The reason we worry is because of the potential for torsade. So what do you do if you have torsade? Well, you're going to look for and treat the underlying cause. If they're in torsade, you're going to shock them. Beta blockers are only for the congenital causes. The other types, you want to actually speed up the heart rate. You're going to shoot for a heart rate of 100 to 120, either using isoproterenol or epi or dopamine or electrical pacing. You shoot for about 100 to 120. Stay away from ACLS drugs. Amiodarone, lidocaine, procainamide, they will all make the QT worse. You never use those drugs in torsade. All right. Let me share with you a case that truly changed my practice. This is back when I was a new attending at Mercy. And back then, back when I was there were no residents overnight. And you'd have 2 attendings signing out to the overnight attending. And it was just you and a PA. And usually PA would start wrapping things up around 1 or 2 in the morning. So I got signed out. It was a really busy shift. It was a very busy night. We're using the hallways as we are now. Everybody out there is using their hallways. And so you kind of have to decide who goes in a hallway off a monitor, who goes in a room. And probably the easiest sign out I got was this. It was a 56-year-old woman who had eaten at a local restaurant. She had nausea, vomiting, maybe some diarrhea. History of hypertension. She's on a diuretic. She looked pretty dehydrated. The sign out I got was, she's in the hallway. I put orders in for some labs and some antiemetics, prochlorperazine, cobazine, and she's going to get some fluids. All you need to do is make sure that she can tolerate POs, check her labs, and send her home in a couple of hours. And she's just getting plugged in right now. So that was the easiest sign out I got. So I'm going around. I'm not even going to look at her. I'm going to go see all of the other patients. And then a little while later, she started on IV fluids. Antiemetics are given. Lights are ordered. An hour later, the nurse checks on her, and she's unresponsive. So she quickly gets the monitor, and she's in polymorphic detach. Right? I don't know how long this has been going on. She hasn't been on a monitor. So we run a code quickly. We shock her. She gets return to spontaneous circulation. And after we get her pulses back, we check a 12 lead. Here's her 12 lead. She's got some PVCs. She's got some ST depression. She's got a long QT. Classic triad 4 hypo K. Right? So I like giving magnesium to people. She had torsades, so we start some magnesium. We eventually got the labs on her, and sure enough, she's very hypomag and very hypo K. Her QTC was 645. She had some ST. That's not syphilis. That's ST depression. All right. And cardiology took her to the cath lab later that day. She had a clean cath. So this code was due to her electrolytes and the prolonged QT. She survived, but with residual hypoxic encephalopathy. The last I heard of her, a couple years later, she was still in a nursing home with a peg in it. Awake and alert woman comes in after eating a bad meal, and she leaves the hospital with a peg in a trach and hypoxic encephalopathy. God awful. And for months and months afterwards, I thought to myself, is there anything that we could have done to prevent it? Is it possible that getting an initial 12 lead might have prevented this? I mean, why do we check electrolytes in the first place? Why bother? We check electrolytes because we're worried that if there's a bad electrolyte problem, they might have an arrhythmia. Isn't that the reason you check electrolytes? That's the only reason you check electrolytes, because you're worried about arrhythmias. Well, what if it takes an hour before you get the electrolytes? And in many cases, it takes an hour before you find out that they're hemolyzed and you have to send them again. What if we were to just check a quick EKG right up front and look at the QT? And if the QT is normal, probably risk stratifies them to a lower concern. But if the QT is long, they're not going to go in the hallway. They're going to go on a monitor until we get those electrolytes back. I'm not saying you do that for everybody, but when somebody looks really dehydrated, as she did, maybe that's a reasonable thing to do. So I started doing that, and then I came across this case, 51-year-old who had acute gastroenteritis, who looked really dehydrated. She was going to get parked in a hallway, and so I thought, well, let's just check a quick 12 lead before she goes in the hallway. Her QTC was 652. So instead of going in the hallway, I said she's got to go on a monitor while we're waiting for the labs. And during the hour or so while waiting for the labs, she did this. She went into torsade. But we knew about it immediately, so we shocked her out of it. It's a life saved. She would have been dead in the hallway. This is an alcoholic who'd come into the hospital often, every Friday and Saturday. He came in with withdrawal. He was nauseous, vomiting, looked very dehydrated. Usually our alcoholics will park in a hallway, and they just sleep it off, or they get fluids or whatever. But this one time, he looked really dehydrated, so I said, you know what, let's check the EKG. And he had flip T-waves, which were old, but what's new was a prolonged QT. So you know what, let's put him on a monitor until we get the labs back. Never been on a monitor. One time we put him on a monitor, and during that hour while we're waiting for labs to come back, we started having intermittent runs of polymorphic detach. That's the second life saved. And then one more case, 39-year-old with acute gastroenteritis, looking very dehydrated. We got a 12 lead. She's got a prolonged QT. So we said, you know what? We're not going to send her back out to the waiting room. We're going to put her on a monitor. While she was on the monitor, she started having runs of polymorphic detach also. 3 lives saved just by checking an EKG because they look really dehydrated. Again, not for everybody, but before you put somebody in the hallway or send them back out to the waiting room, if they look really dehydrated, just check a QT. And that might risk stratify them to whether they should be coming back on a monitor, or maybe they could be back waiting for an hour off a monitor. All right. One other thing I want to talk about with this QT issue, what's the diagnosis here? Long QT, right? But this long QT is a little bit unusual. Most of the time when patients have prolonged QTs, it's because the T wave gets stretched out. In this particular case, the T wave was normal. It's the ST segment that got prolonged. And when you see a prolonged ST segment, there's really only 2 possibilities. Hypothermia, which you should be picking up at triage on thermometer, or hypocalcemia. So as soon as you see this 12-lead ECG, you know the diagnosis is hypocalcemia an hour before the lab. Right? So this turned out to be hypocalcemia because the ST, take a look at leads 2 and 3. The ST is really long. The T wave is normal. That's got to be hypocalcemia. Here's another example. Take a look. The T waves look normal. It's just the ST that's really stretched out. Here's another example. T waves normal. It's just the ST that's really stretched out. This is one of my favorite cases. I've got 10 minutes, but I got to tell you the story anyway. This is about 10 years ago, and I'm working with medical students. Medical students here are wonderful. This was a visiting medical student, and he was a real schmuck. I mean, he was constantly talking about his school, my school. Just shut up. And then, every time I tried to teach him something, he would interrupt me. He would talk right over top of me to try to prove that he knew what I was talking about. Sometimes he'd get it wrong. It's just stop talking and let me finish. Nobody liked him. He was doing an audition elective. We ended up not ranking him, I think. But I hope he's not watching right now. But anyway, and so I just kind of had it with him. And so the patient came in with some shortness of breath and chest pressure. Paramedics brought him in, and I got this 12-lead ECG. And I looked at it and said, this is hypocalcemia, prolonged ST segment, short T wave. So I told him as a student, go see this patient. So he went in, he came out, and he presented the case. And I said, what'd you hear on heart exam? He said, sounded pretty normal. I said, go listen again. So we went back in the room to listen again, came back out, and he's getting a little bit nervous now. So he says, probably a 1 out of 6 murmur. So I said, yeah, right. So I took him back into the room, and we listened to the heart together, and then I pulled him out of the room, and I said, did you hear it? And he said, I just heard a little bit of a murmur. And I said, do they teach physical exam at your medical school? So I'm not normally like that, but he was a real putt. Anyway, so I said, this patient has an S5. So he said, I don't know what that was. So I said, it's a sign of hypocalcemia. So for the next hour, he's looking this up on the internet, trying to find what is an S5. And then an hour later, the calcium comes back 5.8. I was right. And he never talked to me again. It was great. So anyway, we did not rank him. Okay. So I won't do that to any of you, at least especially because you know now. All right, so prolonged QT. Takeaway points for case number 2. If you're really worried about someone's QT, or really worried about somebody's life, just check the QT before you put them in a hallway off a monitor or send them out to the waiting room. Again, I'm not saying you do this for everybody, but when someone looks really dehydrated, you're really worried, just check any case. And you'll get an idea about whether they're at high risk for electrolyte problems an hour before you get to 3 lives saved by doing that. 500 is our magic number that we typically worry about. Magnesium's not always the cure. Again, if the ST is what's prolonged, it's pretty much always hypocalcemia. All right. So last case, talk about pericardial effusion. This is what you classically learn about pericardial effusion. You learn about electrical alternans, tachycardia, low voltage, and cardiomegaly. Well, electrical alternans probably has about 100% sensitivity on the board exam. But in real life, less than 30% of patients with large effusions will actually have alternans. You can't rely on that. It's always in the books. It's always on the boards. It's usually not present in real life. If you see it with everything else, then you can rely on it. Cardiomegaly, everybody's got cardiomegaly with those portable x-rays. So that's not very specific. And then tachycardia may be blunted if somebody's on beta blockers and calcium channel blockers. But I want to give you one simple take-home point from this. Whenever you see this combination of tachycardia plus low voltage, think about and rule out pericardial effusion with your ultrasound. It's real easy. I'm not talking about sliver-size effusions that only Dr. Earl would see. I'm talking about the big effusions that even I could see. Those are the ones that really make a difference. Tachycardia plus low voltage. So that's the whole take-home point. I'm going to show you some cases, but the whole take-home point of case number 3 is whenever you see tachycardia plus low voltage, the first thing you should be thinking of, could this be a pericardial effusion? All right? How do we define low voltage? My definition is very simple. Add up the QRS voltages in leads 1, 2, and 3. If it's less than 15, call it low voltage. Or V1, V2 plus V3, if it's less than 30, call it low voltage. Very simple definition. Differential, there's a handful of things that can cause low voltage. The most common is probably obesity in our population. COPD is common. But if you see tachycardia plus low voltage, think about large effusions, pericardial or pleural. Pleural is easy to rule out. You just get an X-ray. But pericardial often gets missed because all you see is cardiomegaly, and people blow that off because it's so common. All right? If the low voltage is new, then you really need to worry about pericardial effusion before you start them on any anticoagulants. So I'm going to share one of my screw-ups with you, or near screw-ups. This is a 54-year-old woman who came into the emergency department with chest pressure and shortness of breath, history of breast cancer. She's tachycardic and tachypnic, a bit hypoxic. What's the diagnosis? The PE, right? Got breast cancer. She's tachycardic. She's short of breath. PE, piece of cake. So I said to the resident, this is a PE. We got to get a CT angiogram, but there's like a 2-hour delay to angiogram. And I didn't want to wait that long because she kind of looked sick. So I said to the resident, let's start the heparin now. We start the patient on heparin. And here's the EKG, right? And I missed it. You add the QRS complexes in 1, 2, and 3, it's less than 15. Low voltage. You add the QRS complexes in V1 plus V2 plus V3, that's less than 30. So that's low voltage also. You've got 2 reasons to call this low voltage. But I was so stuck on the diagnosis of PE, I didn't notice it. So the patient's sitting there waiting a couple of hours for the CAT scan. By the way, here's the baseline. Take a look at the voltage now. Here's the baseline. You can see the voltage is clearly dropped, right? So finally, they call for the patient. The patient goes over to CAT scan, and then the patient goes over to CAT scan, and there's that overhead. We need a doctor in CAT scan. So I go running over. I'm optimistic. I'm thinking they probably want to thank me for ordering the CAT scan, right? Now, the patient at this point, she's tachycardic, she's diaphoretic, she's sitting up, dripping sweat. We repeat the EKG, and now take a look at the voltage. It's dropped even more. And now when you look at V1 and V2, you can clearly see alternans now. What did we do to her? We put her into hemorrhagic tamponade because of the heparin. She had a pericardial effusion, not a PE the whole time. And that's the danger of that heparin. So we quickly had to send her up to CT surgery. They drained off the effusion. She survived. Very nearly died. This is a case that I had when I was back in Mercy. 62 years old. History of MI, cardiac arrest, tobacco use, end-stage. If this guy shows up in my ER just to visit someone, I'm admitting him, right, with that history, right? He's tachycardic, he's tachypnic, chest X-ray shows massive cardiomegaly, which I just completely blew off. Everyone's got cardiomegaly, I don't care. There's the EKG. Now I was worried about the EKG because in the inferior leads, there's a little bit of elevation. And out laterally, there's T-wave flattening, but here's the baseline. The baseline showed T-wave inversion. So I'm saying to myself, well, he's got pseudo-normalization of his T waves now, and he's got ST elevation in the inferior lead. What I didn't notice is that the voltage has dropped. Look at these limb leads, and here's the baseline. You see how the voltage has dropped significantly? And now he's got low voltage criteria. Add up 1, 2, 3 is less than 15, boom, he's got low voltage. And I was focused on ACS. So I said, well, we've got to admit him to the hospital, right? Gave him aspirin, gave him heparin, and the admitting team saved him and my butt because the admitting team refused to admit him until he got an echo because they were worried about his cardiomegaly. Finally got an echo, and the echo showed impending tamponade, probably worsening because of the heparin. Instead of admitting him to medicine, could die. A couple other cases I'll just show you real quick. 63-year-old guy with prostate cancer and shortness of breath. What's the diagnosis? PE, right? But he's got low voltage in tachycardia. So what's our rule? Rule out pericardial effusion before that heparin. Sure enough, he had a big pericardial effusion from a MET to the pericardium. 46-year-old with breast cancer and shortness of breath. What's the diagnosis? PE, right? Well, she's got low voltage in tachycardia. So we've got to get a A bedside ultrasound first, she ended up having a big pericardial effusion from a MET to the pericardium. We start heparin on these patients, they have a bad outcome. And then here's one more case. Here's one more case. Hopefully. A 36-year-old man, history of IVDA. He's got fevers and shortness of breath. IVDA and fevers, piece of cake. Just send off 13 sets of blood cultures, a minute of medicine. Right? Start some antibiotics. But he's got low voltage plus tachycardia. What's our rule? Get a quick bedside ultrasound before you do anything else. So we got a quick bedside ultrasound, and here's the echo. And he had a big MRSA pericardial effusion. If this guy had gone to medicine to rule out endocarditis, he would have slowly gotten hypotensive, and what would they have done? Broaden the antibiotics. Eventually, he would have died. But fortunately, he went to cardiac surgery and had this MRSA effusion drained off because of following a simple rule. Low voltage plus tachycardia, get a bedside ultrasound. All right? So always consider pericardial effusion when you've got low voltage plus tachycardia. Okay, let's go back and review those first three cases we started with, and then we're done. Case number 1, as you recall, 42-year-old man with the multilobar pneumonia was looking really, really sick. Here's the initial 12-lead EKG. I didn't tell this to you earlier, but right now this patient was so pre-renal, he developed pre-renal failure, and right now his potassium was 7.2. Now, in retrospect, that's a tough call, but if you look at those T waves, they're a little sharp, aren't they? But I'm not sure I would have picked that up anyway. But anyway, he's got a potassium of 7.2. As he was getting worse, he ended up being intubated with succinylcholine. It's one of those cases from a while ago also. Post-intubation, he went into this. Heart rate's 123. What does that mean? Say it with me. It can't be VTAC. But this was called VTAC, and the patient ended up getting lidocaine and died. This was hyperkalemia. After they pronounced him dead, they found that his pre-succinylcholine level was 7.2. Case number 2, 46-year-old who's having intermittent episodes of polymorphic VTAC. She's got a long QT. Those T-wave inversions turn out to be old. What's new? Prolonged QT. And you'll happen to notice that what's special about her prolonged QT is she's got a long ST segment. Look, her T waves look normal. It's just a long ST segment. So what does that mean this is? Hypocalcemia. She got MAG, nothing worked. And then finally, when that was noticed, she got 2 grams of calcium and immediately stopped having episodes of polymorphic VTAC. Life saved. And then there's your T wave. It's normal. It's just the ST segment. And then finally, case number 3 was that 56-year-old that was diagnosed with an inferior lateral STEMI. She ended up getting anticoagulants and antiplatelet agents. She went to the cath lab. What did she die of? Hemorrhagic tamponade. She died on the cath lab table of hemorrhagic tamponade and had clean coroners. If you look back at her original 12-lead EKG, what's she got? She's got low voltage and tachycardia. And this would have been picked up if the first thing they did was just take a look at the heart. They would have seen a big pericardial effusion, which means it's not a STEMI. This is probably related to pericarditis. That's why there's ST segment elevation. She died of hemorrhagic tamponade. All right? So before we break, we'll just go back one more time through the take-home points. Beware slow VTAC. When the heart rate is under 120s to 130s, don't call it VTAC. Think about those mimics. Stay away from ACLS drugs. All right? Case number 2, if you're really worried about somebody's lights, check an EKG first. All right? Not for everybody, but check that EKG. And remember, MAG is not always a cure. And then finally, always consider the diagnosis of pericardial effusion whenever you see low voltage and tachycardia, especially when low voltage is new. With that, I will conclude. And if there's any questions that you all don't have time for, you know my email. And thanks for your attention. Break while we set up for the Q&A.